An update on the continent's response to COVID-19. Africa currently has 644,205 COVID-19 cases, with the SADC region accounting for 50% of the confirmed COVID-19 cases in the continent. Let's go there live.
Vaccine is an interesting one, because if there's an available vaccine today, about 7.8 billion people in the world will be in need of that vaccine. So that manufacturing will need to be decentralized as much as possible. And we are very confident that there are groups on the continent that can manufacture, which is different from producing a vaccine, which means you're doing your own research on it and then producing, find a candidate, test it, and make sure that it works. Then you take it to clinical trials. I think that is something that can be done, but in an emergency, we are saying any vaccine that is promising anywhere and shows promise, we can test it on the continent as much as possible. Lastly is the clinical trials. We want to be sure that the sites are ready. So, for example, if the Oxford vaccine that Lynn mentioned shows promise in South Africa, how can we expand that in several other places across the continent? Given the diversity of our continent, it's a continent of 1.3 billion with 55 countries with all the kind of differences in genetic makeup. So we want to be sure that we are participating fully on it.
All right, thank you. We will invite Professor Lynn just now, but I just want to tell you of another question, related question that also came from Sophie, and she's asking about progress being made by institutions that are participating in the vaccine trials. I know you spoke about member states, but in terms of institutions in Africa or elsewhere, what is the progress on that?
Institutions in Africa?
Or elsewhere.
So again, the whole purpose of the CONVAC, which is the consortium for COVID vaccine trial, is to engage others. For example, this afternoon I will be in discussion with the Gavi, the CEO of Gavi, Dr. Seth Beckley, to discuss exactly how we as a continent can engage with their efforts, the COVAC efforts that they are developing. And secondly, we are in discussions with CEPI, the Coalition for Epidemic Preparedness Innovation, to find ways that we can work together. So I think we have to build these relationships, and as we move on. The institutions in Africa, we've already done a desk review of what clinical sites are available. There are over 80 potential clinical sites, which means they have the ability to enroll participants and follow them carefully. That work has been done already. So I think we are trying to move this as quickly as possible and bring the partnerships. The governing structure is being finalized, which will include co-leads, and then you have a group of stakeholders, the advisory committee, and then technical working groups there. Once that is all finalized, the entire vaccine strategy will be launched once it has been endorsed by the Bureau of the Head of States.
All right, thank you very much. Prof, let me give you 2 to 3 minutes to respond or make a contribution to any of those questions.
Yes, thank you very much. So, yes, I also, right now in South Africa, it's just the one trial that's actually started, but there are a number of discussions ongoing to conduct additional trials. And I think it is important that we do pursue as many of these, promising options as possible, because, vaccines have a high rate of failure. And so we really do need to have a multiple-pronged approach to finding a vaccine. I think one thing that's worth highlighting is, Africa and South Africa as well has a very highly developed network for testing HIV vaccines. And a lot of that experience is proving to be very useful in terms of thinking about testing COVID vaccines. So we can rely on both the clinical infrastructure, also the community awareness about vaccines is there. And also the laboratory capacity to test the vaccines, because I think that's another very important part. As a continent, we also want to be involved in the assessment of these vaccines, and so that we can really contribute meaningfully to finding a vaccine. I think another very important aspect John touched on is the manufacturing, and that is something that I think we really do need to, as a continent, we need to build, because there's going to be huge demand for a vaccine when one is available. And of course, we as a continent need to be able to produce and manufacture our own vaccines. I think that's something that we really should, we should think about. And then, there's a very important question of who gets vaccinated, that whole, and there's, I know, lots of discussions at many levels at Gavi and CEPI around access and equity to make sure that really the vaccines get to the people who need them most. And of course, in an ongoing epidemic, it would be the healthcare workers primarily who would be prioritized in terms of getting a vaccine. But I also don't want to run ahead of myself right now, because we're still in the very early stages of vaccine development. And as I mentioned, vaccines, it is a complicated process. As many of you know, we don't have a vaccine yet against HIV, despite a lot of effort. And so, right now there's a lot of optimism, that we'll be able to develop a COVID vaccine. But of course, we don't have any solid data yet. What we do know is that the vaccines that are being tested, and there are over 150 that are in development. I think right now is around 30 already in human clinical trials. What we do know is that they are immunogenic. They are stimulating the right kinds of immune responses. Whether those immune responses are protective or not is obviously what we need to assess. So there's a lot of work ahead. It's not a shoo-in. It's not a definite. People are very optimistic because of a number of things about the virus. One is it's genetically very stable, unlike HIV, which changes all the time. And also because the vaccines so far have produced the right kind of immune responses. So there is a lot of optimism, but at the same time, I think we need to get the evidence and the data to really know for sure, where this is headed. Thank you.
All right, thank you very much. We move on to someone who's joining us live, and that is Joseph Abuje of Africa Science News in Kenya. Good morning, Joseph. Hello, Joseph. Joseph, please unmute your microphone so that we can hear you. All right.
Hello?
Hello, good morning, Joseph.
Morning.
Fine, thanks. Please go on with your question.
Okay, my question was, or is, our country, Kenya, we have had some areas being locked down. And the infection, we have seen the president lifted the lockdowns, he allowed the movement of people around the country, but we have seen the trend of infection even going higher. So does it mean maybe that something's not being done right to curtail the infection of COVID-19?
Yeah. Good. Thank you, Joseph, for your contribution again this week, as always. There are two things we have to note. One is that as our testing increases, we'll find more cases. I think if you test more, you'll find more. I think that is one. We have to always remember that. Second is that as we unlock our economy and people move around, you will see the increase in infections. The most important thing, as Lynn has said, is that and I indicated in my closing remarks, is to intensify our public health tools that we have in our hand. That is, ramp up testing, make sure that we increase contact tracing, that we social distance as much as possible, and wear masks. Those are the tools that are available in our toolkits, and we have to use those tools effectively. For now, without a vaccine, without treatment, that's all we have. So there is not much you can advise countries to do other than to say that they should decentralize testing as much as possible, but increase the turnaround time so that the testing is not done as if it's a malaria test or an HIV test where you can do it and then return after 2 weeks and get the result. But you reduce the time between the collection of specimens to when you return the results to the patient and you act on the results. I think that is the most important thing that needs to be done with testing. It's not the number of tests as such, but what you do with the test results.
Okay, thank you. Can we now...
If these measures are not implemented. If the measures are not implemented, we'll even be in for a very, very long haul. But if the measures are implemented, as we saw in other countries that have successfully fought and won this battle, for example, Japan, Singapore, and other countries, and New Zealand, and Mauritius, right? There will be, then we have a chance to fight and win this battle. So again, strong community ownership, strong community engagement, strong community response is the cornerstone of our for us to defeat this virus.
Thank you very much, John. We move on to Mark Schenkel, and Mark has a question for Professor Morris. Mark?
Yes, good morning. Thank you. My name is Mark. Morning, yes. Professor Morris, how do you explain South Africa's relatively low case fatality rate?
Yes, Mark, that's a very good question. The short answer is we don't know. Obviously, we're very thankful that is the case, but obviously, when we did the models to predict the deaths, we planned on that, and so it's it is really important for us to understand, and so that when we plan for when the epidemic really takes off in other parts of the country, that we can plan correctly. So there have been some hypotheses. One of them is that, we do have a younger population in Africa in general, and of course in South Africa. And we know that this virus, age is a major risk factor for death for this virus. So that is certainly one potential factor. The other factor is that, we are, in terms of the global epidemic, Africa is, as we all know, is behind the sort of the wave. And that we've had the opportunity to implement some of the clinical interventions or improvements, including dexamethasone, which we are using in South Africa, and that may have played a role. Of course, the other thing about case fatality, it's in relation to the number of cases. And, we have done a lot of tests in South Africa, as I said, over 2.2 million. And so that would, of course, also... of course, that's an artificial kind of measurement because, the testing is dependent on your lab infrastructure. But, it could also just be the large number of tests that we've done. So it is something that we definitely need to investigate. Of course, there are lots of other, I guess, sort of less solid hypotheses out there that also need to be, I guess, investigated to some extent. But, I think... right now, also the focus really does need to be on trying to, preserve or to keep these low death rates as the epidemic starts moving through the rest of South Africa, and we hope that remains. Thanks.
Thank you very much for that. We have questions. Do you want to make a comment?
Yeah, maybe I just add to that the low death rates is not only in South Africa. If you listen to the numbers I presented this earlier on carefully, I said there were about 644,000 cases as of today with 14,000 deaths. And it's very important to note that these deaths are very skewed to two countries. Egypt has recorded about 4,000 death cases, and then South Africa about 4,400 cases there. And then A distant third is Algeria with about 1,000 cases there. So if you combine just South Africa and Egypt, they're accounting for 8,000 deaths of the 14,000, which is more than half of the entire continental deaths there. So the caveat here, as Lynn said, is that are we counting everybody? Okay, because of our fragile and weak mortality surveillance systems, is it possible that we are not counting all the deaths in the community appropriately? We just don't know. We are only 6 months into this pandemic and on our continent, 6 to 7 months. So there's still a lot that we are learning from it, and still a lot that we need to put in place to capture everything that we need to know about either the number of testing, the prevalence, and the mortality.
Our next question is coming from Tamar Khan, and Tamar is with the Science and Health. He or she, Tamar, is the Health and Science writer for Business Day in South Africa. And Tamar has questions both for Dr. John and Professor Morris. The one for Dr. John: what role do you see for pooled testing for COVID-19 in Africa? And then the one for Professor Morris is, can you comment on the feasibility of pooled testing for South Africa, given the current state of its epidemic? We'll start with you, Dr. John.
No, thank you. I think pool testing is a known technique that we've used in other infectious diseases, where essentially you collect specimens, say, from a certain number of people, bring them all together, and then test. And then you decide if that collection, we call it pool, is positive, then you unpack it, and then you do additional testing one by one. So I think that is known. However, you have to be sure that the prevalence of the disease is at a certain level in the country. So if the prevalence is high, that is the number of people infected at every given moment is high, then pooling becomes very complicated, because you do very large number of tests and then redo it again. So that if your numbers are low, then pool testing, as Ghana started doing, makes sense to implement that. Let me just add something here and say that we are very early on in even developing the right test for COVID-19. The dominant test that is driving the testing now is what you call the PCR based test. That is the polymerase chain reaction test. Is accurate, is sensitive, specific, but it requires a lot of multiple steps and is difficult to decentralize. We are hoping that with time, and I'm hoping that within months, we have antigen-based tests, which will measure the proteins that the virus will produce, called the antigens. And that way you can easily decentralize the test into the community and decrease that turnaround time. Remember, I'm insisting on the turnaround time, which is defined as the time which you collect the sample and then give the results back to the patient, because that is what is going to be critical and determinant in following up the patients that are positive, isolating them and tracing their contacts.
Prof?
Yes, no, thank you for that question. So pooling is, as John mentioned, a very standard technique to really, also save on your reagents, because, if you pool, for example, 10 samples together, you're only doing one test, but you get 10 results, assuming they're all negative. Obviously, if more samples as more infections are happening, or you're testing groups of people that have higher rates of positivity, pooling actually becomes, in fact, counterproductive, because you have to go back and test them all individually. So you end up doing more tests. But pooling is a very useful strategy in low prevalence settings. And certainly we were doing it in South Africa when we had a community testing program where the prevalence was very low. And pooling was very useful because, as I said, it saved reagents, it saved take time, it meant faster turnaround times for results. So very useful. But actually, we have stopped using it now in South Africa because our testing strategy is focused now on the high priority tests. And those are, people in hospitals, healthcare workers, people in old age homes, or people with comorbidities. And so we really stopped the pooling for now. And And if we do go back to more community testing, maybe when the epidemic starts to come, the curve starts to come down, pooling may well be introduced at a later stage. Thank you.
Thank you very much. We go back online and let me call upon Sarah of DevEx. Sarah Jerving. Hello, Sarah.
Sorry about that. Thank you for taking my question. I'm just wondering if you can talk a bit more about what the role of the Africa CDC is in Tanzania's response and kind of what the coordination relationship is. And then also, I've heard that the Ministry of Health in Tanzania is providing alerts to people, kind of like organizations like WHO. I'm wondering if Africa CDC is also getting alerts, and what defines alerts if it's not caseloads.
I didn't.
Sarah, can I ask you to speak just a little bit louder?
Oh, sure. Sorry. Can you hear me?
Yes, we can hear you now.
Okay, sorry about that. So I am wondering if you can talk a bit more about what the role Africa CDC in Tanzania's COVID-19 response, what is kind of the coordination relationship. And I've also heard that Tanzania's Ministry of Health is releasing alerts to WHO. Is Africa CDC receiving alerts from the Ministry of Health? And if so, kind of what defines an alert? Like what's included in alert if it's not an actual kind of case number count? Thank you.
No, thank you. I mean, in terms of coordination, let me respond this way, as I've done before. I mean, Tanzania is an important member of the African Union, one of the 55 member states. And we all agreed on the need to have a joint continental strategy that is underpinned by coordination and cooperation and coordination and, of course, communication. The communication piece is that releasing of the results in a timely fashion or reporting to us as much as possible. Tanzania, the Africa CDC is a member states organization. I think it's all through the wisdom and the vision of the head of states that they decided to create a specialized public health agency for the continent. So we expect Tanzania to be an active member and to comply with all the commitments and engagements that as a member of the African Union they are entitled to. So with respect to the release of the results, we have not yet received those alerts, so it's difficult for me to comment on things that we have not seen. So we will continue to, as I said, actively engage with Tanzania, encouraging them to interact with their own organization, which is Africa CDC, as much as possible. It offers a two-way traffic that we also identify areas that we can provide technical assistance to Africa CDC and to Tanzania from Africa CDC in several areas of response, testing, and infection control, prevention, and surveillance, and others. So we are extremely open to engaging with the authorities in Tanzania at any time.
Cara Anna from Associated Press has a question for Prof. Morris, and she says, what is the average turnaround for a result of the tests now in South Africa, especially in Gauteng and in the Eastern Cape? And what, if any, are the concerns around testing in South Africa? So those are two questions for you, Prof.
Yes, thank you. Very important questions because turnaround time is critical for these tests to be of use. If we're doing contact tracing, we need to get that result out quickly so that contacts can be confirmed. And obviously for hospitalized patients, a test means that once they're confirmed, they will then be put into a COVID ward rather than waiting. and being potentially exposed while in hospital. If they're actually negative, you want to get them put into other wards as quickly as possible. So the turnaround time is really a critical factor. The turnaround times are, for it to be effective, be within 48 hours or 72 hours, ideally 48 hours for the test to be, for the result to come back. Some labs are doing it within 24 hours, which obviously is ideal. But as the numbers ramp up, that gets much more difficult. So the turnaround times also vary a lot between provinces, between laboratories, and also between the private and the public sector. There's quite a lot of variation. And that speaks a lot to, just the capacity of each of the laboratories, also the number of specimens that they receive. So, many of you who follow the South African situation will know that we had a very big backlog at one stage, largely because of the huge community testing program that we had in South Africa. And that really, the turnarounds were up to 2 weeks in some cases. And that really becomes very problematic. I am pleased to say that the turnarounds have come down around the country. I think there is a little bit of a backlog in the Eastern Cape and Gauteng, but I know that is improving. So it's a critical factor. If you're really interested in it, actually the NICD publishes a weekly testing report. It's on our website, and we actually document the number of tests that are done by all the labs, and also the turnaround times, for the private and the public sector labs. So you're welcome to go and have a look at that. Thank you.
We're coming out of that Center for Disease Control media press briefing, and we'll try to go back there as soon as we're able to. That link just went weaker on us. A breaking story now for